such as punctate calcification, diffuse infiltration. Then I would get a baseline ultrasound and reassure the patient to have an ultrasound repeated in a year. Because you will find too many patients with sub-centimeter papillary carcinomas who don't need to have anything done. So generally, if it's only a few millimeter nodule, no adverse features, simple follow-up.
Wait and see. I think after your talk, which you gave in the beginning of the lecture, this was a wait and see approach.
Yes, I think that the ultrasound is very helpful in the examination of thyroid gland, also in this situation, and especially fine needle aspiration to see what is inside, if we can say. But we have, as I mentioned earlier, a lot of small cancer, microcarcinoma, 3 millimeter in diameter, which is diagnosed with the fine needle aspiration. And I think that it is a problem. It becomes a bigger and bigger problem. We are managing more and more really small carcinoma. It is easy to say, Jatin, just say it isn't so dangerous. You can live many years, but they are forcing, and they are coming to me with the opinion of the other doctors that it is necessary to do surgery. My last case, 3 days before, it was a young man, 32 years old, with 5 millimeter papillary carcinoma. He was scared, totally scared. Yeah? And what to do? I explained him that it isn't so serious disease, but he answered me, Doctor, I want to be operated tomorrow.
Professor Ang, what do you say?
No, I don't see those patients. Yeah.
Okay.
Fortunately.
Okay. Jan Olofsson.
We are seeing 4 times more. We are diagnosing 4 times more of thyroid carcinomas. That is from 8,000 to nearly 30,000. The mortality rate is not going up. You see the same number of that is dying from it. Does it mean that we have a better diagnosis, or are we or are we operating too many cases unnecessary?
Both.
I have a question for my colleagues. Now, I think when we updated our data and show that local regional control rate for patients who we treated after recurrence, now our surgeons are presenting cases to us, say, after first surgery, there is an obvious extracapsular extension with closed margins. And I'm in a dilemma. I don't have any data to show that radiation would help. What are your thoughts?
I think it's a good point you are making up. If the primary tumor is a well-differentiated tumor, and the patient is young, I would be inclined to treat that patient with radioiodine.
Yeah.
Conversely, if it's an older patient who is thyroglobulin non-producing, has a poorly differentiated carcinoma, it's as good as treating a squamous cancer.
Yeah.
And therefore, that patient is not an iodine candidate. That patient will go on to external RT.
Yeah. Okay. One last comment before we close this session.
Dr. Shah, you mentioned that for a significant proportion, possibly the majority of patients with thyroid cancer, the life expectancy approximates that of a normal population. And much of the confusion that arises in their management subsequently, as you showed, comes from the word cancer, which they carry in their diagnosis. What do you think the implications might be of us actually considering renaming certain this majority of the of this disease as benign. I don't know what you might call it, multifocal adenoma or disseminated adenoma.
Or good point you are making. This is a thought. There was a thyroid cancer nomenclature meeting of pathologists in northern Italy, I forget, a few years ago. And Van Rossi suggested that we call it papillary tumor and not papillary carcinoma. But the WHO won't buy that because histologically it shows mitosis, therefore it's got to be called cancer. But your point is well taken. A similar situation is the mucoepidermal carcinoma of the parotid gland, low grade. We often call it mucoepidermal tumor. So your point is well taken. We spend more time with patients with non-lethal cancers, telling them you don't need treatment, than the time we spend with patients who have lethal cancer and who need desperate treatment.
It gives another DRG.
Well, we are facing with this problem in patients with prostate cancer, non-palpable prostate cancer with PSA of 4. And I can sympathize with you saying that we can tell them you do not need treatment, and then they are so nervous, they are plotting out the PSA curves, they say, why it increased by 0.2, and then they are rushing into our center. They say, should I get protons? They say, wow, that's over-treatment.
Well, I would like to thank the panel. I think maybe we have raised more questions than we have answered, but I think we have a good discussion. Thank you very much. Thank you.